Now, in this next section, you're gonna be talking about the principal elements of the treatment paradigm that you have preliminarily designed, and it's going to include medication as well as alternative interventions. So can you start out by talking to us about the two mood stabilizers that you have studied and found to be effective?
Yeah, well, sure. And let me just lithium and is the gold standard for treating bipolar disorder. But before I want to sort of start with a caveat, and that is, as we talk about ketamine as a treatment for FOH, but this condition is, at least as we've found it and defined it, is a subtype of bipolar disorder, and we believe it's a thermoregulatory subtype, but you can't use ketamine in these patients until you've really stabilized the mood, and that becomes the first order of business. And you have to be very, very careful that you have, and we sometimes wait 3 weeks or longer to make sure that the individual is stable before we introduce the idea of a ketamine trial. So lithium, is sort of, in those of us that treat bipolar disorder, it goes without saying that it is the first choice. And over the years, the studies have shown, both in adults and also in youth, that that it is really should be the first line drug. Although the studies that have been funded by essentially pharmaceutical companies have led a lot of researchers to study antipsychotics, and which are they're now considered mood stabilizers, which is a real misnomer. And don't let anybody fool you. None of them have been found to have a maintenance effect on maintaining mood stability, but lithium has. And
Dr.
so
Papolos, I hate to interrupt you, but I have to ask a question here about the lithium, because so many prescribers are reluctant to use lithium despite all the many years of research that we have showing its effectiveness, and even more, they balk at the blood levels that you have identified as being the therapeutic range. Can you share with our audience your clinical experience here, all the many years you've had as a practicing psychiatrist regarding lithium, why it's the recommended here as the primary mood stabilizer, and why levels of 1.0 to 1.2 are really what's needed?
Yeah. Well, I mean, going back to the adult literature, I mean, if you think of, these children are continuously cycling, right? They are not in and out. I mean, they're in and out very rapidly out of an episode, but they are chronically, their moods are chronically unstable. So they're, in many ways, have a continuous acute episode. And this is the way I think about it anyway. And in adults that are acutely manic and something's not working, particularly lithium, you titrate the dose upward to tolerability. You're not treating a blood level. You're not trying to get up to somewhere between this range. This is just a guide. I mean, people can have a response at a much lower level, and may not have a response until you get to 2.0. So there's a real range of responses, and it's pretty idiosyncratic. So you can't predict, in a sense, in advance how a particular how lithium may work in an individual. But we found that that there's until you get up to this range, you don't typically see much of an effect in kids with this particular syndrome. And and sometimes you can't because notoriously the therapeutic range is quite close to toxicity. So you have to be one. You wouldn't want to. You want to make sure that parents understand if they're going to select this as a treatment for their child, that they have to be pretty hypervigilant. They have to be, one of the things that's important to do is to buffer the blood with electrolytes, pretty much every day, particularly as they get up into these higher ranges, and to make sure that children don't get dehydrated, because that's the way in which you can get toxic. So those are important caveats in terms of introducing the drug. You titrate it to clinical response, or if there are side effects that intervene that are not tolerable, then obviously you don't go any higher, and you lower the dose. And then at that point, that's when you might need a second mood stabilizer, and that can often happen to try to stabilize the mood. So this is not a easy condition to treat by any means, the same is true with oxcarbazepine, although it is, I would say, as a drug, in terms of its safety index, it would be considered a much safer drug in that way. It's been shown to have broad effectiveness in psychiatric conditions in childhood and adolescence. It doesn't have the track record that lithium has, certainly, but it's pretty well tolerated, and I will often use it as a supportive medication along with lithium if lithium doesn't, you can't, doesn't work for whatever reason. But what I would say is that lithium really should be the first line, because, and particularly if there's a family history of a parent or first-degree relative who's had bipolar disorder that responded to lithium, because that the response to lithium is definitely a heritable phenomena. And if you respond to lithium, wow, you're very lucky. It's about maybe 60% of individuals that have the condition have a really good response, and often don't need much else. So there are many reasons to use lithium. Also, and the thing that really appeals to me, I mean, pretty much at the get-go whether you're going to be recommending ketamine for the child, because lithium does not have a great deal of an effect on the fear of harm symptoms. So lithium has been shown in animal studies to be neuroprotective in general and in humans. In fact, it's being used in some quarters to treat dementia, not as a single treatment, but as a protective drug, and it also has been shown in animal studies to prevent the potential negative effects of ketamine. And these are studies that are done in infant rat pups, where they give, 15 times the dose that during the period of time that the brain is most highly developing. So it's an incredibly vulnerable time, and they give, almost, toxic doses of ketamine, and then when they do that, they see lesions in the hippocampus and other problems, vacuoles in the hippocampus, I should say. And the ketamine, when given prior, lithium, when given prior to that dosing, protects the brain from that. So it another reason, to justify its use as a first line treatment in this syndrome.
Dr. Papolos, a lot of prescribers, especially when they're dealing with children, seem to rely on lamotrigine or Lamictal as the primary mood stabilizer. And I noticed that you do not have it on this list. Can you share your clinical experience as to why you?
And I, I want to say I wouldn't, take what I say with a grain of salt because I'm not preferably lithium, which is a salt, but lamotrigine, Lamictal, is a I would say it's an excellent antidepressant, first line antidepressant for bipolar disorder. Works very well typically if you have a patient who's you've stabilized their the manic hypomanic periods, and yet they still have these depressions. That would be one significant. That would be the choice in my mind. But it can be activating at a certain dose, and increases irritability and increases hypomanic symptoms. So I have shied away from using it for that reason. That's what I would see not infrequently in my adult practice. So it's not something I have a great deal of experience with and haven't prescribed in these children. I mean, that's a study that, probably somebody should do.
Thank you for sharing your clinical experience because you truly have a wealth of knowledge from the practical application of all of these ideas with your patients. So thank you for
Sure.
sharing that. Um, Now, you've also found success with adjunctive treatments pertaining to body temperature and temperature regulation. Why don't you talk about those?
Sure. So the other part of the treatment protocol is really to deal with the heat dissipation problem and trying to cool down and release heat from these individuals. Because I should say, so when we get up in the morning, we're at our coldest because we have dissipated heat. We haven't generated heat much during the night, and their body's been just getting rid of heat. I mean, that's one of the things that happens when you lie down for a length of time, and then when you get up in the morning, you're cold, or you can feel cold. Certainly, these kids feel very cold in the morning, and then immediately your mind starts working, your brain starts working, your muscles are working, and you're generating heat and energy, and that, if you're not dissipating it, in a prospective way over the course of the day, it's going to get sequestered in the core and you're going to heat up. And that's what happens with these kids. And also, there's a physiological phenomena that's called stress-induced hyperthermia, which we all have to one degree or another. That is, if you encounter stressors, you can get your body responds by preparing you, by generating some energy and getting you ready to fight or flight, and that produces heat. Well, for these kids, not only are they experiencing multiple stressors because they're misperceiving things as fearful throughout the day, but they are not dissipating heat, so they get hotter and hotter over the course of the day. So one of the ways in which we've found that we can, affect that aspect of this is with both medications and also with basic cooling strategies. So here in this slide, we're basically looking at clonidine, which is introduced as an antihypertensive in its first life many years ago. But it's one of those drugs that we found has a remarkable effect on both the dissipation of heat and also on heat generation. So it improves heat dissipation significantly because it opens up, it's a vasodilator, it opens up blood vessels all over the body. And that's how you get one of the ways in which your body is getting rid of heat to to the skin. It's just the blood vessels are sending it off basically. So it's greater surface area and you're dissipating more heat. And it works pretty well. The problem is it's also can be sedating. So you have to titrate it very carefully. And typically during the day, if we use it, it's given in sometimes, mostly it's given as extended release, usually at noon and also at bedtime to help with the overheating that occurs right before sleep, and also the immediate release clonidine we use 0.1 to 0.3 milligrams, typically not during the day, but mostly to help with sleep onset because it helps to dissipate much of that accumulated heat. And we also will give extended release through the night, and that really can help those sleep symptoms that we've talked about. And also melatonin, also a peripheral vasodilator, and also helps to dissipate heat. And this is something typically that we give in microgram quantities because that's typically all anybody needs. What's sold in the over the counter are often very, very high doses that are unnecessarily high. And so we give it in microgram quantities, both an immediate release and an extended release, so that they have an effect right away, and then it continues throughout the night. So those are two of the drugs that we've found to be helpful and effective for heat dissipation and cooling.
Now, there are also non-pharmacological interventions for heat dissipation and cooling.
Yeah, well, I think as any sleep specialist would tell you, if you want to sleep well, you keep the bedroom really cool. Somewhere between 68 and 72 degrees. For anybody, that's true. I mean, you really get much better refreshed sleep, typically more deep sleep. And the same is true for these children, although they often like it much cooler than that. And there are all sorts of aspects of this. You need to find out what the nighttime temperature and humidity is in their room. Humidity is a major factor. When there's a lot of humidity in the air, it's harder for the body to pump off heat because it's basic physics. You're pumping up against the gradient. And so, depending on where you live and you want to make sure that there's a constant cool temperature at night and that the air is not humid in the room. The other, maybe most significant way of dissipating heat for, again, anyone is just immersing yourself in lukewarm water, and particularly your trunk. And 15, 20 minutes before sleep, half an hour before sleep, and maybe in the middle of the afternoon. These are two very effective ways of getting rid of heat, and preferably is done proactively throughout the day. And I think we have another slide that talks about those interventions.
So this
right?
would be the slide talking about drinking ice water multiple times a day, using a ventilating fan throughout the day, and also for sleep. And there's a real schedule you have here for the ventilating fan and the cooling neck wraps and cold packs.
Right. And we typically begin at 12 noon, and we wanted both. You want to cool the gut, which is the core. I mean, that's where, you measure the core temperature. And by drinking ice water, really ice water, multiple times a day, you're going to cool the gut down. To push air off the body by ventilating is also important. There are different types of fans. Most of these kids end up using a personal neck fan that is rechargeable, also throughout sleep. But most of these uh, need to be, we suggest starting at noon, because that's when they're, by that point, typically they've generated too much heat. Every 2 hours, about 15 to 20 minutes of doing all three of these things, including putting these a cooling neck wrap or cold packs, or these things called ice necklaces that you can wear, you can buy and wear. And, and then if you do that every 2 hours, you're essentially working proactively to reduce this incredible heat load. And then potentially you don't have this overheating at night, which then produces the sleep disturbances that we've talked about.
So step one is addressing the mood dysregulation with the mood stabilizers. Step two is addressing heat dissipation and cooling through both pharmacological and non-pharmacological interventions. And then step three is now we move into reducing the fear and releasing the heat through the use of ketamine.
Yes, exactly. We talked about how ketamine may do that. And once you stabilize the mood, you can introduce ketamine, and it's easily available through a compounding pharmacy. Typically, we use a 100 milligram per ml concentration, sometimes as high as 150. Can't go higher than that because it'll crystallize out of solution. And we use a 0.1 milligram metered spray, which delivers 10 milligrams per spray. And then we've also been using sublingual troches. This is ketamine put into this a vehicle, a tablet that dissolves under the tongue. Typically, we use we start with 20 milligrams a day, and then use 2 to 3 days between administrations of the ketamine. And the target dose is usually between 80 and 260 milligrams a day. So, and this is again 2 to 3 days between administrations. And that's the beginning. And then you essentially, go on you do a slow titration, starting from 20 milligrams. And we really titrate the clinical response, which is how they are scoring on essentially a list of the items that specific from the FOH target symptoms, the behaviors that they manifest, their own individual customized behaviors that are rated typically by their parents on a daily basis. And you follow them initially weekly, and they're also monitoring the side effects for 1 to 3 hours after administration. And on a weekly basis, you review the target symptoms and side effects with the patient and family, and you can increase the dose usually by 10 or 15 milligrams, sometimes more, depending on, the nature of the side effects that you've seen, every 10 to 12 days.
So, Dr. Papolos, I know some folks have difficulty telling the difference between the mood symptoms and the symptoms that the ketamine is designed to treat, that are triggered by the temperature dysregulation. So we can concretize those symptoms that we'd be looking at specifically to identify symptom remission with these that the ketamine is designed to target.
Yes, exactly. These are specifically some of the symptoms that I won't go through the list. You can read it along, but these are we've talked about most of these symptoms, and these are the things that are on the list that parents are rating, and they similar. These are basically part of the fear of harm trait.
So clinicians and parents should not be surprised when the mood stabilizing medications don't address these symptoms. Then that's not an indication that the mood stabilization isn't working. It means that these symptoms are specifically derived from that fear of harm and temperature dysregulation features of FOH. And so we're really seeing these symptoms being addressed by the ketamine, not by the mood stabilizers.
Yes, that's a very important point. Thank you for mentioning that.
Now, there's also the circadian rhythm instability. Dr. Papolos, can you talk more about how those symptoms are regulated?
Yes. So this circadian rhythm problem has to do with, and this really, I'm not going to go into all the details, but suffice to say that temperature and body temperature, the circadian rhythm of body temperature and the circadian rhythm of the sleep-wake cycle are coupled, and melatonin is one of the couplers of these two rhythms, and these rhythms are essentially uncoupled or uncoupling, I should say, because of the thermoregulatory problem that these kids have. One of the things that we found, not treats, but certainly can help, is melatonin, before sleep, and also what device that's called the dawn dust simulator. So it's a device that you can buy. You put it in the room and you program it to go off whenever you want to produce dusk in the child's room. You have to have blackout curtains so you're not getting any light leakage, but it literally produces a light that just gradually goes down, just like natural dusk, like you're outside in the woods and there's not a cloud in the sky. And it does the same thing during dawn simulation. It begins to go off whenever you want it to, and it proceeds for half an hour, delivering a very natural dawn. And this is a real synchronizer of the circadian light-dark sleep-wake cycle, and it adds it provides a really clear Zeitgeber, that's natural, and that these kids tend to respond to. Again, it's not a independent treatment. It's something to boost the effectiveness of the other parts of the protocol.
And then we also see that you recommend the blue light, sometimes exposure and sometimes blocking.
Yes. So blue wavelength light, these are blue photons that are coming at dawn, and they're typically what leads to arousal. And you don't want to be getting those like half an hour or even an hour before sleep, and all of the devices that these kids are Velcroed to often are delivering blue photons and in abundance. So either they have to be wearing glasses that are blue wave blockers, or the screens have to be really, you have to use a blue blocker screen so that they're not exposed to that kind of stimulation. So those are, and then that would be, I would say, for several hours before bed. But also it can be a real time giver, a Zeitgeber in the morning to tell you, okay, this is the time I want to wake up. So on awakening, we'll often give, just 10, 15 minutes sometimes of a blue wavelength light, even less, as a signal, but at the same time every day to get the child up. Now, most of these kids, we haven't talked about it, before they're treated, have sleep inertia. They can't get up in the morning. They're groggy, they fight getting up, and largely because they've had such poor sleep. But this will lead to a more earlier arousal time.
So now, before we wrap up for today, I know that you wanted to address the issue and underscore some of the unhelpful treatments that kids are exposed to before they get an accurate diagnosis and effective treatment for this disorder.
Yeah, sure. Well, two of these are stimulants and antidepressants. And, I mean, pretty much it's been, I don't know why it's not part of common practice, but I mean, it's pretty much been established in adult, research with bipolar disorder that these drugs really are antidepressants are absolutely not effective and actually make things worse over the course of the illness. And stimulants, for several reasons, are very activating. I mean, they're stimulants. They're essentially methylamphetamine, and they can really wreak havoc particularly when not used judiciously and after the moods are stabilized. They will induce rapid cycling, suicidal ideation, psychosis. I mean, these kids don't tolerate these drugs, and they're frequently prescribed for these children because they're always diagnosed first with ADHD. Antipsychotic medications, they certainly have a place, but they can they're problematic in terms of their potential effect on thermoregulation. And I mean, it's almost impossible not to use them, but certainly they should not be used as a first line treatment for the bipolar disorder, in this group anyway, in my opinion.
So, to just ground this very briefly in the lived experience of children and families, I want to share with our audience a typical report from parents on how their children are doing once they've been able to access this groundbreaking treatment for this disorder. And this is a quote from a parent: "Things are really good now, and they have been since we finally found a doctor who understood what was going on. He put our son on the right medications and took him off the wrong ones. It's been life-changing for us and totally life-changing for him. It was incredibly good fortune that we happened to find the right people, and it so easily could not have happened. I don't even want to contemplate where things would be today if that were the case." So these treatments that we've been lucky enough to have Dr. Papolos share with us are truly life-changing for the patients who need them. So we're very grateful to all of the clinicians who are attending this special webinar series. And I want to remind everyone that next time the entire session will be a live Q&A with Dr. Papolos on the history, on the development of the treatment paradigm, and on its implementation. So we will be collecting all of the questions that have been asked in the Q&A, and we will bring them to our final session in 2 weeks. Because of the wonderfully enormous response that we've had to this series, we are going to be breaking it into 2 smaller sessions so that people will have the opportunity to speak directly with us and with Dr. Papolos on this topic.